So a very good evening to all of you. I request all my co-instructors to please take a seat on the dais. Dr. JB sir, Dr. Manisha, Dr. Mudit, Dr. Amit is here, Dr. Padma. So I welcome you all to the instruction course on learning lessons in uveitis practice. Slides. So as you all know, I have an esteemed panel of faculty who are my co-instructors in this course, and I look forward to their talks, and I look forward to the active participation from the audience. You're free to ask us any questions whenever the time permits us. Dr. JB sir, may I have you on the stage, dais please? Dr. Padma. So at the beginning of the instruction course, do we have Dr. Peter McLuxy here? He had his keynote lecture. So as I think we'll wait for Dr. Peter McLuxy, who will be delivering his keynote lecture. So we'll start with the talks by our co-instructors. I would be happy to present my talk at the end after my co-instructors present. So can we start with you, Dr. JB sir? So sir will be talking on fluorescein angiography in posterior uveitis. When is it required and when not? And sir needs no introduction.
So no introduction. Can you open?
It's not coming on the screen. Just wait. It's not coming on the screen. Yeah.
I'd like to thank Dr. REEMA for giving me this opportunity and particularly asking me to talk on fundus fluorescent angiogram in posterior uveitis, when it is required and when not. I started using fundus fluorescent angiogram way back in about 30 years or even 35 years. And that time serpiginous choroiditis was one of the most common indication for me, and Eales disease. Over the years, I learned a lot about fundus fluorescent angiogram in posterior uveitis. I just share my cases. This is my opinion. This is a 40-year-old man who had a painless, no pain, redness, gradual, no pain, redness, gradual dimness of vision for 3 months. Look at the fundus picture. Do you think it's choroiditis? And do you need a FFA? Of course, you need an FFA. Is it choroiditis? It's no. It's multiple leak CSR. And if you look at the picture, it's very difficult to tell looking at it. And fundus fluorescent angiogram gives the clue. To me, this is the most important indication for me for FFA in posterior uveitis, because it's a diametrically opposite treatment you will be providing the patient. This is a patient came with a CNBM, suspected CNBM, with a scar over the macular area. What is the cause of the CNBM with apparently normal fundus otherwise? If you do a fundus fluorescent angiogram, you will see that punctate hyperfluorescence and suggestive of peak. You may not do much in this case, but you can get a diagnosis of punctate inner choroidopathy. This is a case of retinal vasculitis. Do you need a FFA? Obviously, this patient will require intensive laboratory investigations to rule out TB, sarcoid, collagen disease. But do you need an FFA? Obviously, yes. The reason is that you can see that veno-venous shunt, occlusive retinal vasculitis, veno-venous shunt, capillary gauze capillary non-perfusion, microaneurysms, and this all indicates the possibility of a disease which you call Eales disease, now considered to be thought to be immunological reaction to the mycobacterium tuberculosis DNA. And this patient's treatment will be requiring corticosteroids and anti-tubercular medications to me. And you may miss this such a subtle neovascularization which can be picked up by fundus fluorescent angiogram, and cystoid macular edema that also can be picked up. This is a patient to 30-year-old man, gradual dimness of vision, MANTU positivity, and there is a choroiditis lesions over here. If you do a fundus fluorescent angiogram, you will see that typical ring of halo, ring of fire there around it, and it is very typical of TB choroidal granuloma. Not that TB choroidal granuloma have other fluorescent angiogram pattern, but this is quite suggestive of. In case of sarcoidosis, you will be seeing an hypofluorescence and which become totally hyperfluorescent lesion. You don't see the ring of fire appearance in case of sarcoid granuloma. Is there another situations where you need a fundus fluorescent angiogram is that mutes, multiple evanescence into Hunter syndrome. This is a 20-year-old female complaint of sudden scotoma, flu-like fever 1 week back. But if you do a fundus fluorescent angiogram, you see around the fovea wreath of hyperfluorescence. And of course, ICG can show that hyposenescence lesion. So multiple evanescent white dot syndrome is the diagnosis. Fundus picture may not show these subtle spots, white dot syndromes. In a case of SLE, fundus fluorescent angiogram is required. It gives a area of capillary non-perfusion and amount of capillary non-perfusion as seen in this picture. And here is you can see the retinal vasculitis with gross capillary non-perfusion in the case of SLE. 3 months after treatment with immunosuppressive agents, there is a complete resolution of inflammation. And this is the patient. After that, we did the aggressive laser photocoagulation and could preserve the vision. And this is another situation where elegantly fundus fluorescent angiogram can show this is the IR1, the idiopathic retinal arteritis, vasculitis, and neuroretinitis, aneurysm and neuroretinitis. And you can see the beading of the blood vessels, which elegantly shown by the fluorescent angiogram. And this is that. This is the fundus fluorescent angiogram. Sorry, this is the fundus fluorescent angiogram. I will be showing in a case of VKH, sensory retinal detachment, in that one in both the eyes. Fundus fluorescent angiogram showed punctate pinpoint leaks, study skies pattern, and pulling of the dye in the late phase. This is in the other eye has got symmetrical picture. Early is a multiple pinpoint leak, mid-late pooling of the dye. Of course, Swepsosity has now come and has been aided in the diagnosis. This is a case of Base's disease where you can see the gross capillary non-perfusion, capillary farning over their lesions, and this is quite suggestive of Base's disease. In case of serpiginous choroiditis in active and inactive age, the active serpiginous choroiditis would be showing hyperfluorescent border, and the central area will be hyperfluorescence. Of course, autofluorescence can be useful to monitor the disease process. FFA can identify the several complications like here is a CNVM. This I have taken long time back, about 20 years back. I take the photograph, and that time OCT was not there. Fundus fluorescent angiogram, lacy hyperfluorescence was seen. In case of cystoid macular edema, OCT is better, but to monitor the disease process, but fundus fluorescent angiogram can show petaloid hyperfluorescence. In summary, for diagnosis like mutes, APM-PPE, we can use that FFA. To determine the extent of choroidal involvement, ICG is better, but a fluorescent can show the lesion. To follow the disease process and to identify the complications like CNVM as well as cystoid macular edema. This is in short FFA indications and relative position in now in our armamentarium. Thank you very much.
Thank you, sir, for covering this very important topic, because fluorescein in geography is a very important tool, imaging tool. And when it comes to any ophthalmologist in practice, when seeing a patient of uveitis, I think we should be able to differentiate where to do it, when to do it. So thank you very much, sir. Any questions you can note down and we can take up at the end of the session. So with this, we now move on to our second presentation by Dr. Manisha Agarwal, who will be talking on mistakes in infectious uveitis. So this is a very important topic again, because we all make mistakes in our practice, however experienced we are. So these are some of the pearls that Dr. Manisha is going to teach us. And you all know Manisha is the head of the vitreoretinal services and uveitis services in New Delhi in Dr. Shroff's Charity Eye Hospital. Dr. Manisha, please.
So, very good evening to all of you, and thank you, REEMA, for making me a part of your IC. And I think we make mistakes day in and day out, but from each mistake, if we get to learn something, I think nothing better can happen. So, what can be the most common mistakes that we can really be doing when we are dealing with infectious uveitis? The first would be that we are diagnosing it as a non-infectious uveitis. So we are actually dealing with infectious pathology, but we'll end up diagnosing it as non-infectious. We can diagnose it as some other infection. So we've reached one step further, that we were sure that we were dealing with infectious uveitis, but we are diagnosing it as another infection, though it turns out to be another one. And then, last but not the least, when you fall in love with your diagnosis. So we fall in love with our girlfriend and boyfriend, but here we are falling in love with your diagnosis and we are stuck with it, not ready to revise our diagnosis. So let me give you some very interesting 3 clinical examples, and which are going to justify where I'm coming from. So this is a 68-year-old male patient with sudden diminution of vision in the right eye 10 days back, and now having a blurring of vision in the left eye for last 5 days. He had a history of paralysis of left side of the face 6 years back, hypertensive for 6 years, history of CAD with bypass surgery also done, and he had stopped ecosprin 6 months back. He had been diagnosed as a branch retinal arteriolar occlusion in the right eye somewhere else and referred to the treating cardiologist, because the treating ophthalmologist thought that there was a French episode of BRAO, because the patient had stopped ecosprin. And the patient went to the cardiologist and the ecosprin was started again. The problem was that this patient started losing vision in the left eye, and the left eye vision had dropped to 636 and 36. When the patient came to me, because he was getting worried, you see that in the right eye you have this typical retinal whitening, which is suggestive of a branch retinal arteriolar occlusion, but in the left eye you see vitritis and you do see an optic nerve head swelling. So I go ahead and dilate the fundus of both the eyes, and this is what you see in the periphery, where you see these typical creamy tongue-shaped lesions which are present in the periphery of the other eye. And these are very classical of acute retinal necrosis in the left eye periphery is what I found. So this is just an OCT. And when we investigate this patient, apparently he comes out positive for all the viruses. And patient is started on antiviral treatment. Ecosprin is very much continued, which is indicated. And the left eye being the better eye of the patient, we start treating the patient with intravitreal ganciclovir. Oral steroids are started 3 days after having started antivirals, and the risk of RD is explained to the patient. At follow-up at 1 week, the right eye, the vision is finger counting at 2 meters, but you see how beautifully the lesions have cleared up in the left eye. But apparently the patient, because there was a delay in starting the treatment, there was sclerosis of the vessels, there was involvement of the optic nerve head, and the vision had dropped to as low as finger counting at 1 meters. This is how it looked at 1 week, and at 3 weeks the patient had recovered a vision of about 3/60. We went ahead and did a laser barrage in the left eye and to avoid a retinal detachment to occur. 2 months follow-up, the patient had recovered a vision of 3/60 in the left eye and 636 in the right eye. So when I reviewed the literature, because I had never known that you could have vascular occlusion secondary to an infectious pathology, to my surprise, I came across these references where BRA has been described as a presenting sign of ARN, and you can actually have combined vascular occlusions as the initial presentation of ARN in the fellow eye. So this again was a very important learning for us. The possible mechanism being that there may be presence of subclinical inflammation in the right eye causing the release of inflammatory mediators which may disrupt the blood flow causing thrombus formation and arteriolar occlusion. So here we had an infectious pathology, but the mistake was that it was diagnosed as non-infectious and which resulted in a delay in the treatment. Now coming to the second mistake, diagnosing it as some other infection. So let's go ahead. This is a 45-year-old male patient with sudden blurring of vision for last 15 days, having cough with expectoration for last 1 month. The vision in the right eye 660 and 36. And this is how the fundus of the right eye looks. Now, where he had been seen elsewhere, he had been diagnosed as a frosted branch meningitis and started on antiviral therapy along with oral steroids. But the patient was really not responding. Again, the patient had a occlusive vasculitis in the left eye with macular edema. Now, the investigations which the patient was carrying with him was all the viral titer, because the ophthalmologist had very much diagnosed it as a viral pathology, and the patient was already on oral antiviral therapy for last 1 month. We did not suspect a viral pathology. So we went ahead and investigated him further, and rightly so, the Mantux came out to be strongly positive. The CECT was also suggestive of that, and we started this patient on ADT and oral steroids. And this is the timeline of the patient. You see the drastic improvement which is happening, and the patient from as low a vision of 660 improved to 69 in the right eye, and the left eye, you see how beautifully the entire inflammation is gone and the patient has recovered a good vision. So we went ahead and published this case also, where the tubercular retinal vasculitis was mimicking a frosted branch meningitis, and that's why the previous ophthalmologist had gone wrong, and this patient had been referred to me from Aligarh. Now coming to the last mistake, and that is falling in love with your diagnosis. So let me again give you a very interesting case example which will beautifully prove this. So this is a 21-year-old girl, sudden painful diminution of vision in the left eye for last 10 days, evening rise of fever, cough, weakness, typhoid fever 2 months back. The vision in the left eye is counting finger close to face. She is totally colorblind, and this is how her left eye fundus looks, where you have a huge granuloma sitting on the optic nerve head. Vasculitis is there, huge granuloma in the macular area, and if you can appreciate those small petechial hemorrhages which are very typical of a tubercular granuloma. So we thought we have a bang on diagnosis. All the investigations again were very much suggestive of an underlying tubercular pathology, so there was absolutely no doubt. The patient was started on anti-tubercular therapy. Steroids were given, and of course topical atropine and prednisolone eye drops. The patient started responding very well. You had a beautiful regression of the ONH granuloma, and also there was more aggregation of the macular granuloma. So we were very sure that the patient is responding well. But now, to our utter surprise, the patient comes back with the involvement of the macular area which was not previously involved. So there was a kind of a rebounds phenomena of the inflammation, and we really didn't know how to explain this. Simple, we diagnosed it as a paradoxical reaction, and the patient was treated with IVMP with high dose of oral steroids, but despite that, we lost this eye. The patient went into neovascular complications, started developing NVI, exudative RD. Out of desperation, we started the patient on ofloxacin as a second-line ATT, and it became a painful blind eye with extensive neovascularization, and we also treated this patient with multiple Avastin injections. The eye was removed and it was sent to JB Sir, and he confirmed that the patient very much had granulomas which were very much suggestive of a tubercular etiology. And this is how the young girl, she looked after the cosmetic correction. Now, follow up, the patient was on ATT for 1.5 years. Fresh lesions now started developing in her chest. So a bronchoalveolar lavage was done and the sample was sent for culture and sensitivity. PCR and gene expert PCR was done this time because we had no reason why the patient was still doing badly after having given ATT. So everything done. Now the PCR for Mycobacterium tuberculosis came out positive with both the primers, but also what we discovered this time that the gene expert PCR showed that the patient had a rifampicin resistance. And this patient was actually suffering from a multi-drug resistant tuberculosis and therefore kept deteriorating despite being on ATT and steroids. So we went ahead and published this case also because this was a learning for us that you cannot just sit back and relax that you started the patient on ATT and steroids and everything is going to now fall in place. So you have to be open to revise the diagnosis if there is something which is not responding to your treatment or keeps coming back as a recurrence or keeps worsening despite being on treatment. So I would just conclude my talk by saying that we must rule out an infectious etiology before diagnosing it as a non-infectious. A careful history taking from the patient and detailed clinical examination often gives us a clue to the right diagnosis, and we should always be open up to read up and revise our diagnosis to make mistakes and then repent later. Thank you so much for your patient listening.
Thank you, Manisha, for the excellent cases and the documentations. So with this, we now move on to non-infectious uveitis. So we do make mistakes in non-infectious uveitis also. And for this, we have Dr. Amit Khosla. He's a very senior consultant in Sir Ganga Ram Hospital in New Delhi. And he's in the department of uvea and vitreoretinal surgery. So Dr. Amit, please.
Good evening. Thank you, Dr. REEMA, for inviting me. So in uveitis, there's always the goal to prevent vision loss, and we always worry about the side effects. If you worry too much of the side effects, you will not control the disease. So the common mistake we make is that we tend to taper the steroids very fast, 10 milligrams. So you need to bring it down to almost 2.5 milligram per week before you taper it off. So you take about 3 months if you feel it's a posterior uveitis. Don't try to taper out standard 6 weeks regimens of tapering the steroids. And if at the end of say 3 weeks you feel that the patient still requires about 0.5 milligram per kg body weight, think of immunosuppression because 90% of the patients will require immunosuppression. So we have learned from rheumatology that we don't control the disease, we want remission. That is, remission means both clinically and on diagnostic you have a remission of the disease. Because if you were to taper the steroid when you have say activity on the FA or on the ICG, you may have a recurrence. So the focused guidelines tell us that an inactive disease or remission is when the anterior chamber cells are less than 0.5, there's a 2-step down in inflammation, then you think that the control is coming, it's not remission free. So as mentioned, we always are worried about the masquerades. We are always worried whether it's infective. So I think REEMA's lecture on infection versus non-infection was the most crucial one. Sometimes we make an incorrect diagnosis, or we start the treatment too late, or we have inadequate immunosuppression. So everyone who's interested in management uveitis should read this focus initiative. We tell you what is the optimal time for treatment escalation, when should you transit to a non-steroidal drug, and it's preferable to have a multidisciplinary team collaboration. Here's a patient of 35 years who came with blurring of vision, looks like VKH, right? But we checked, the patient was on checkpoint inhibitors, which itself can cause uveitis. So it's important that the history should also be taken before you make a diagnosis. Here's a child who came with recurrent hypopyon and vitritis. Came in like this, and then we did a vitrectomy, couldn't find any organism, but on detailed history, the child had taken part in a fancy dress program where the eye had been hit by a thorn. So it could have been an infection, but we were not able to localize. We did anything. So history is important. So the other controversy we always has TB versus sarcoidosis. Remember that if you do not have active pulmonary tuberculosis or any other lesions, you can give steroids as a first line, then add the ATT. So there is a patient who had tuberculosis a few years back, had this reaction. This patient was put on steroid, added MMF after 3 months, has 6/6 vision. So the inflammatory component of TB or looks like sarcoid can be there. Here's a patient, a 40-year-old female who was diagnosed elsewhere as VKH. You can see the FA, you can see the ICG. Patient was given steroid, had a complete remission, had a recurrence, came to me with this right-sided granuloma. I started the patient on steroid and methotrexate. The granuloma doesn't disappear. On this, you feel that the right eye is fine, the left eye is fine. So we added adalimumab. Now, if I go back to the previous slide, if we were to see the FA here, it has activity, but the eye. So you can see this patient, this has activity in the right eye. Left eye, the FA doesn't show any activity on follow-up, but the ICG shows. So the left eye was also active. So you have to use all the tools. So if you, before you stop treatment in a VKH, get an ICG done or an OCT angiography, but ICG is better, will tell you of the active disease at the end of, so otherwise you will lose the eye. Here's a patient who came in the non-biological era who had this picture, vitritis, hyperemic disc, retinal lesion, Behçet's disease. We tried everything, steroid, azathioprine, cyclosporin, we had all the complication. So from 12 to 15, we were burning our hands, we couldn't get the vision back. And ADA came in, 2015 we gave, and suddenly the media became clearer, the child gained 1 line of vision. So being aggressive at the right time, then start planning to give steroid intravitally, and going to the next level of immunosuppression helps you save the eye. Here's a patient, a staff nurse in our hospital who postpartum had a fever for 1 day, had this lesion. Now, you always worried, is it vasculitis? It is infective or non-infective, post-fever retinitis. So you hold your hands for a few days, you give an antiviral, you give antibiotics to see how the patient is responding. We did every test possible from scrub to wheel Felix. Finally, we did the tap, and we have a PCR test which we normally use for meningitis, has all the viruses, and the patient was negative for all. So we started on oral steroid, gave Razumab for the edema, and we did the angiography later. So these patients can later go into ischemia and NV formation. See the extensive NV, despite laser multiple injection, took us about a year to control this NV. Sometimes post-fever retinitis can have vascular and you think it's resolved, but you need to look for NVDs, NVEs, and also sometimes uveitis can also miss a CNVM. Here's a patient just referred to me 2 days back with poliosis. The initial exudative RD diagnosis was diagnosed as VKH. So after 2 months, the patient came with 612 vision on steroid on Azuran. So when presented to us, the vision had 612 and 624. So the child required more immunosuppression, has already developed sunset. So it's already late. You need to increase the immunosuppression early. So we started the patient on adalimumab. This was already the outer retina has disruption. So we sent for a wide field angiography, and you see how much activity is still present in the angiography. So we started the patient on biologics. As mentioned, you need to use FA, ICG, you need autofluorescence and OCT angio to be really sure that you have controlled it. You can't do FA regularly. So autofluorescence helps you to make a diagnosis of a healed serpiginous like choroiditis, and it's non-invasive. So in summary, you must identify the characteristic, rule out infections, and plan for immunosuppression day 1. If you feel that this patient is severe, use the focus guidelines to think that you must, by the 3rd week, start immunosuppression, because after 3 months, the steroids are going to take a toll on the patient. Here's a patient, 2002, I had just bought the digital camera. So this patient was diagnosed as a CRAO type picture. We did the fluorescein, had vasculitis. Patient was given methotrexate, went through all highs and lows of steroid-induced depression to aggression and side effects. But the patient still comes back after 20 years and has 6/6 vision. So patient was put on methotrexate for 2 years, and you find the resolution. Now this patient came to me, was a VKH, well resolved, was having intolerance to Azuran. I started the patient of MMF, but I overlooked the pigment. I didn't do the ICG. I felt, oh, the FA is normal, the OCT is normal, clinically patient is 6/6. And see how gradually it started to become fainter and fainter until developed a sunset syndrome in both the eyes. So you can see, if you see the photograph from the beginning, the change is occurring, and I am overlooking the change every visit for 5 months. So if I had an ICG or I referred the patient for ICG, I would have picked it up. So the patient is still on ADA. I started ADA at this point. The patient is 6/6 even after 2 years. So you have to be aggressive, and you have to think at the right time. The patient requires an increase in the immunosuppression. Here's a patient who came with pan uveitis in the lockdown with total posterior synechia, ruled out tuberculosis, This is what the child had. So in children, you tend to stop steroids within 3 months, all topical and oral, because you don't want to scatter and glaucoma. So you can see how the child resolved and has 6/6 vision. Start the patient on adalimumab at 3 months. So it's important to understand when to introduce the DMARDs, which one to use, when to escalate. And the commonest mistake we make is that we taper the steroid and we start the immunosuppression late, and you have a phase of time when you have patients who have recurrence and you think, oh, was my diagnosis right? So for those who are interested, do go through the focus guidelines. I won't go into detail, but it's important to understand that macular edema is not an urgency to treat. You can take some time to make a diagnosis. And these are the indications in that article which tell you. And the most important thing is that now that people are using biologicals, I'll just end my talk. So you must talk about family planning with patients who are on methotrexate and MMF. And all immunosuppression take time for them to act, and you must have the patience to plan and wait. So before you stop the immunosuppression, wait 2 years at least before you start to taper the drugs in severe posterior uveitis. So especially those who have anti-TNF, sometimes you feel that those are not acting. So you can increase the dose to adalimumab to weekly. You can switch to other ones because sometimes you have an antibody formation, golimumab. You can start, or you can combine with other drugs, or you can do a local treatment. So finally, it is not a stepwise. You can jump from one step to the other when you're using immunosuppression, and you can use intermittently the steroid implants or something when you feel that it is not responding. But don't use it as a single treatment because they only work for 3 to 6 months. Thank you so much.
Thank you, Dr. Amit, for your tips on non-infectious uveitis, especially when it comes to making mistakes in these kind of patients. So with this, we now move on to our next talk of the session on when laboratory investigations are not required. This is by Dr. Padma Malini Mahendradas. Of course, you all know her. She is the Vice President of Uveitis Society of India and is currently heading the uveitis services at Narayana Nethralaya, Bangalore. And she's going to cover one of the most important topics again for the general ophthalmologists who see uvea patients, where we all tend to order a battery of tests when actually it may not be required. Dr. Padma.
Thank you, Dr. REEMA, for the kind introduction and invitation. Very good evening to all of you. The topic was given to me was, do we always need to investigate? Whenever a patient presents to us, we need to tailor-make the investigations and try to find out the cause. The standard approach to uveitis is a stepwise. We'll take good history taking, examination, investigations, and management. Now, we have to avoid investigations. Without that, how are you going to manage? In which cases can we skip the investigations? Here is a case of a lens-induced uveitis. When the lens is the culprit and inflammation is secondary to that, we address the cause in addition to appropriate anti-inflammatory therapy where you don't have to investigate. What I mean is laboratory investigations are not required. Second is a traumatic uveitis. It's a blunt trauma which resulted in uveitis. You treat these patients with anti-inflammatory therapy and closely follow up for the development of secondary complications. Or in a case of a penetrating trauma which is self-healed, no evidence of infection. Once the inflammation, they respond well to anti-inflammatory therapy. The fourth entity is whenever we have granulomatous panuveitis, conditions like sympathetic ophthalmia, that there is an history of injury involving the ciliary body that is exciting high, following which if the patient develops panuveitis, inflammation of the anterior and posterior segment of the sympathizing eye, you are dealing with a case of sympathetic ophthalmia. We don't need investigations to make the diagnosis. However, we order investigations to start the patient on treatment and monitor the response to treatment with systemic steroids and systemic immunosuppressive therapy. The next is a case of a VKH where we have bilateral exudative detachment. We make the diagnosis based on the clinical presentation. These extraocular manifestations like alopecia, poliosis, vitiligo, tinnitus are all developed later in the part of the disease. The next entity is Fuchs uveitic syndrome. Most often, it is underdiagnosed and overtreated with corticosteroid therapy. In the textbooks, wise Fuchs does not need investigations, but we do ACTAP for PCR for viral genome if you are suspecting a conditions like CMV anterior uveitis or other viral uveitic entities. So to summarize, whenever we see a patient with case of a lens-induced uveitis, Fuchs, traumatic uveitis, the literature says first episode of acute non-granulomatous anterior uveitis we don't investigate, but I like to do a thorough systemic evaluation. If I find any history of low backache or other systemic findings, I like to investigate even in the presence of first episode. We need to tailor make the investigations based upon the clinical presentation. The VKH and sympathetic, these are the entities where we don't order laboratory investigations to make the diagnosis. Since it's a case-based, now we'll move on to the cases. 78-year-old man presented with redness and pain watering in the right eye since 2 days. On examination, circumciliary congestion, 2+ cells and flare, fundus examination was normal. We would like to start the patient on topical steroids and cycloplegic agents and try to find out what could be the reason. But on systemic evaluation, the patient had viral wart in the periocular region. On probing the history, patient used topical phodophylline, following which he developed redness in the eye. So this is adverse drug reaction. Probability scale of 7 was obtained, suggesting that anterior uveitis in this case was probably secondary to the use of topical podophyllin. Topical podophyllin was stopped and topical steroids and cycloplegic were continued, which resulted in resolution of the inflammation in this case. Next, move on to the case 2. It's a 37-year-old lady presented with complaints of redness and discomfort in both eyes. Defective vision on and off for 9 months, and she gives history of flu-like illness. She is also known asthmatic, and for eye inflammation she has been using topical prednisolone, timolol, and she used for oral moxifloxacin for the systemic flu-like illness. On anterior segment, you could see fixed mid-dilated pupil, deep anterior chamber with patchy depigmentation of the iris. There was a flare, occasional pigmented cells. Pigments over the endothelium was seen, and this is not the cells, active cells. These are pigmented cells floating in the anterior chamber of the eye and also the anterior segment of the lens. You could see few depigmented patches on the iris. The gonioscopy revealed open angle with pigmentation of the trabecular meshwork, where we could see the heavy pigmentation of the trabecular meshwork in both eyes. Fundus was absolutely fine. What could be the diagnosis? We made the diagnosis of bilateral acute depigmentation of the iris, what we call it as BARDI, following systemic moxifloxacin use for the flu-like illness. Here, topical steroids were stopped. Anti-glaucoma medication was continued for some time. This is a progressive, and after some time this stabilizes and the repigmentation of the iris appears. So conditions like BARDI, we do not treat them with topical steroids. You just observe with close monitoring of the intraocular pressure. This is a drug-induced uveitis due to various agents like PG analogous contraindicated in uveitis, and quinolones, especially the systemic ones, can cause body-like syndrome. Recently, we have among the vaccines, COVID also have been listed up. Next case is a 52-year-old male presented with recurrent postoperative uveitis. Here is the patient is taking recurrent uveitis for the past 4 months. Whenever you use the topical steroids, inflammation comes down, and after stopping it comes back. There is no systemic history, is absolutely fine. Posterior segment is absolutely normal. On close slit lamp biomicroscopic examination, we could see the presence of cotton thread in the side port. That is the reason. So, as long as the patient is using the steroids, inflammation is under control. The minute they stop, it comes back. Here, cotton thread was removed. Subsequently, there was complete resolution of the inflammation. So these conditions like this, we don't investigate. Case 4 is a 16-year-old boy presented with redness and pain, watering and blurring of vision since 2 months. He had circumciliary congestions, fibrinous anterior uveitis, already had a posterior synechiae. Fundus showed hyperemia of the disc with media haze. Here again, during the COVID time, when we probed the history, what clinically we made the diagnosis of panuveitis. When we did the fundus when we did the systemic examination, we saw the inflammation of the gum, what we call it as a gingivitis. The patient was put on systemic antimicrobial and anti-inflammatory therapy with topical steroids, which resulted in resolution of the inflammation. So if the eye cannot see, what the mind does not know. To summarize, we saw 3+1 4 cases where the investigations were not necessary. Gingivitis, podophyllin-induced toxic uveitis, and bilateral acute depigmentation of the iris, and post-cataract presence of cotton fibers. So this highlighting the importance of thorough clinical examination to finding out the cause of uveitis, in which case we do not have to investigate this patient unnecessarily. I'd like to acknowledge her team. Thank you for your attention.
Thank you very much, Padma, for these wonderful cases. So we now move on to our next talk by Dr. Mudit Tyagi. We'll be talking on when should you suspect masquerade. So when should you have a high index of suspicion? And Dr. Mudit is a senior consultant in the uvea and vitreoretinal services in LV Prasad Eye Hospital, Hyderabad.
Yes, good evening, and first of all, let me thank Dr. REEMA for having me as a part of this wonderful instruction course. So I'll be speaking about masquerades in uveitis. Now, what do we mean when we say masquerades? It's not moving. Yep. So masquerade syndromes are essentially a group of disorders that can present with inflammation, but are in fact non-inflammatory to start with. So you will have inflammation, but it is secondary to another initial disorder. Now this is a patient who presented with a hypopyon. This image is courtesy one of my colleagues, Dr. Anamika Patel. And this was a patient who presented with this pigmented hypopyon. If you can see some inferior pigments over here, this thick hypopyon in a kid. And whenever you see a brown colored hypopyon, you must understand why is it first of all of that color. That can be sometimes because of a necrotic iris and dispersed melanin granules, and that can be essentially sometimes a clue to a underlying uveal melanoma. Similarly, in a kid, if you see a hypopyon with otherwise quiet eye, you should also keep a differential of retinoblastoma in mind. So the point is, when do you suspect masquerades? You suspect masquerades when the presentation is either not typical of what you expect, or it is probably not responding to the way you are treating it and is not going on the expected lines. So whenever you see a patient whose inflammation is not responding to your treatment or is slightly atypical, it becomes important for us to keep in mind a differential of masquerade. And let me show you a few common ones. So this was a patient who was a known diabetic who came to our clinic with a sudden decrease in vision in both eyes. He had a hypopyon in the left eye, but look at what's happening in the right eye. You this essentially this large blood clot and this blood stained hypopyon. So when we did a tap of this patient in a peripheral smear, the peripheral smear revealed the presence of myeloblasts and metamyelocytes. So blood stained hypopyon can be a clue to an underlying blood dyscrasia. This was not inflammation otherwise, but a blood dyscrasia to start with. Similarly, remember presence of a hypopyon in a case of leukemia should alert us to a possibility of either a relapse or a lymphoid blast crisis in case of CML. It can also indicate a presence of a CNS spread and a leptomeningeal involvement. So one more case, and this is a point which Dr. Padma had shown in one of her slides, but let me show you two very illustrative examples of. So this was a patient who presented to us with PL plus PR inaccurate vision in both the eyes, had a dense fibrinous reaction with no view of pupil and iris, was initially diagnosed as uveitis alpha, started on steroids, but the point is that at this point of time she had shallow AC and stromal edema, was having an elevated IOP. Somebody in fact even tried attempting a PI in this patient because of the shallow ACs. But if you go back and look at the history, and that's why history becomes so important, because apart from the inflammation which the patient had in anterior chamber, patient also had choroidal detachments, peripheral CDs in both eyes. And when we went back and asked her, she was taking topiramate. Now, topiramate is a drug which is known to cause not only angle closure but also a hypopyon uveitis. So this was a patient with a drug-induced anti-uveitis with choroidal effusion. The idea was to stop topiramate, start them on topical steroids, and this is what happened. We stopped topiramate, started them on steroids and cycloplegics. The edema starts regressing in terms of corneal edema. AC becomes more well-formed, fibrinous membrane regresses. Visual acuity improved to 20/60 and 2200 initially, and then subsequently improved to 20/40, 20/50 in both the eyes. This is how the patient is. Final visual acuity in the left eye though was 23/20, but that was on account of cataractous changes which the patient had. Another patient, again hypopyon uveitis, somebody attempted doing a surgical PI, but again this was a patient who was taking topiramate. The treatment in these cases is to discontinue topiramate or any incriminated drug and start them on steroids. So whenever a patient presents with this hypopyon with bilateral angle closure, keep in mind a differential of drug-induced uveitis, topiramate, chlorthalidone, hydrochlorothiazide, acetazolamide, all of them are known to occasionally cause angle closure. And in elevated IOP, Diamox actually is contraindicated in these cases because that in itself can aggravate the condition. Another case with this extensive membrane, if you look over here, somebody attempted doing a cataract extraction in this case of intumescent cataract, but what this patient had actually was a chlorthalidone induced inflammation, and you needed to just stop chlorthalidone and you would not have landed up in this mess that we have over here. Ultimately, we ended up removing these membranes and doing a vitrectomy, but all of this could have been avoided if we had taken care of taking a good meticulous history and eliciting a history of the drugs which the patient is using. So chlorthalidone, indapamide, topiramate, common agents, more commonly topiramate, which can cause such a presentation. Hypopyon uveitis in a patient on treatment for tuberculosis, think of rifabutin toxicity. That can be a drug-induced toxicity. So remember, the point over here is that when you see such hypopyons, keep in mind a differential of drug-induced uveitis. Now one more case, this was a patient with significant vitritis, multiple yellowish subretinal sub-RP lesions and optic nerve infiltration in the right eye, and you can see these pigmented changes over here with creamy yellow lesions with yellow infiltrates and leopard spots, and the other eye or the fellow eye had multiple yellowish sub-RP lesions. A B scan revealed subretinal heterogeneous diffuse infiltrating lesion with localized RD and optic nerve infiltration, but look at what we find on OCT. OCT shows this characteristic sub-RP infiltrates. You see sub-RP infiltrates, sub-RP lesions. This was actually a case of primary intraocular lymphoma. So OCT can be extremely helpful in these cases. So this was a bilateral primary vitreoretinal lymphoma over here. Again, another patient with these multiple lesions over here, one well demarcated separate pale yellow lesion over here in the periphery with vascular sheathing. And OCT again through the lesion shows these RP deposits and these RP changes. Again, this was a patient of a vitreoretinal lymphoma. So when you see these lesions and these characteristic RP changes and features on OCT, keep in mind one of the possibilities of a lymphoma, and a biopsy can be extremely helpful in these cases. One more patient presents with this elevated nodular lesion over here with surrounding subretinal fluid, and at this point of time our differentials can be probably choroidal granuloma, scleritis or choroidal metastasis. But when you go back and take a history, this patient gives history of a right axillary mass excision in recent past. This was a case of choroidal mets, and when you go ahead and do an FFA over here, you see in the recirculation phase extensive peripheral hyperfluorescence with a central hypo. OCT shows this nodular lumpy bumpy choroidal lesion along with subfibrinous fluid over here, bacillary layer detachment. So this was a patient of choroidal metastasis, and therefore it's extremely important to take a good meticulous history in all cases of uveitis. That essentially forms a backbone of how we diagnose most of our diseases. So the points to remember are, whenever there are atypical presentations, things to consider will be: number one, recalcitrant blood-stained hypopyons can be a clue to underlying blood dyscrasias. Remember, bilateral hypopyon plus choroidal detachment, drugs like topiramate. So take a history of what drugs are your patients using. Dr. Amit Khoslide in one of his talks had shown a patient who was taking JAK kinase inhibitors and presented with a VKH-like picture. Hypopyons in leukemia patients are an indicator of impending blast crisis or CNS spread. A high index of suspicion and a meticulous history taking and clinical evaluation are essential to avoid these pitfalls and diagnose masquerades in the first place. Thank you so much.
Thank you, Dr. Mudit. And I think you've highlighted the very important point that masquerades is something we always have to keep in mind.
Yeah.
So we'll move on to the next talk. And the last talk of the session is by Dr. REEMA Bansal. She is a professor at PGI Chandigarh, and she has several publications to her credit in uveitis. So Dr. REEMA is going to be speaking to us on learning lessons in uveitis practice.
So, a very good evening to all of you once again, and I'm very thankful to my co-instructors for giving such wonderful talks and maintaining the time limit. So, I wanted to speak at the end after listening to all the talks in my session, and now I present a few points on the clinical clues on infectious versus non-infectious uveitis. So you may find some overlaps because these are the general teachings that we have, and we know when we target ophthalmologists who are seeing uvea patients also. So when we talk of inflammation versus infection, or an infection versus a non-infection, there are some basic primary differences. Like the infection, as we all know, is caused by invasion of the body tissues by a pathogen, and infection is not always present when there is inflammation. On the other hand, inflammation is the response of our body to any biological insult, and inflammation is always present when there is infection. So when we look at the uveitis signs of both infectious and non-infectious uveitis, we have certain signs which are common, like keratic precipitates, fibrinous anterior uveitis, or hypopyon, and retinal vasculitis. But there are some signs which are exclusively dedicated to infectious uveitis like retinitis, unless it's a Behçet's disease. But we all know how frequent we see retinitis in Behçet's. So it's a very rare sign to develop when there is Behçet's, because primarily Behçet's presents with hypopyon and vasculitis and choroiditis. So by and large, if you're seeing choroiditis, you should think of a non-infectious uveitis. So with this, I'll present few examples of hypopyon where we can differentiate between infectious and non-infectious. So we had this 43-year-old male who was a known case of cutaneous malignant melanoma, had undergone 3 cycles of chemotherapy, and came to us with a sudden loss of vision in both the eyes, left more than right. This is the clinical picture. His right eye vision was hand motions, left eye was only light perception. These look like two different patients, but they are the same, right and left eyes of the same patient. Now the difference and the similarities in the two eyes are, you can see there is hypopyon in both the eyes, but the difference in the hypopyon in the right eye is it's a streak hypopyon. It is accompanied by fibrin in the pupillary area. The pupil is fairly well dilating. On the other hand, the left eye hypopyon is a straight, layered, thick hypopyon, very much white in color. We tried to dilate the pupil did not dilate. There is a lot of lid edema, partly ptosis, and a lot of chemosis. Now, are you dealing with the same etiology in both the eyes? Maybe yes, because it's the same patient. So this was quite a challenge for us. What are we dealing with? So let's see what we did with the right eye. When we dilated the right eye, we could not see much in the posterior segment. All that we saw was the glow. Now this amount of fibrin does not necessarily allow only a glow to be seen. We expected much more clinical details. So since the patient was bilaterally almost blind, we offered a diagnostic and a therapeutic vitrectomy in the right eye, and we took up the patient for vitrectomy. This is 3 days post vitrectomy. We had put him on topical steroids. We did not start oral steroids because we were not sure what we are dealing with. So now you can see the fibrin is gone, hypopyon is gone, primarily because the topical steroids were there, and also partly because the vitrectomy was done and we had debulked the vitreous. We started gradually to see the fundus, and this is the post-op follow-up where we could hazily see the fundus, and the media was kind of grade 3, and on inferior down gaze we could see these exudates. So this was an endophthalmitis in the right eye, and endogenous endophthalmitis because he was post chemotherapy, so probably an immunosuppressed patient who developed endogenous endophthalmitis. So the right eye was doing well, and we did not do anything in the left eye. We did not touch the left eye, and this we told the patient that we are not going to do anything with your left eye because we want to know something from your right eye biopsy, what we are dealing with. So by the time we had some response in the right eye, maybe a week or 10 days later, the left eye chemosis had gone down, the hypopyon had disappeared. Only thing that we did was we started him on IV antibiotics because we wanted to take care of the chemosis and the proptosis. We were not sure whether it's orbital cellulitis. So this was the response, and you can see the left eye has turned very soon into a blind eye. We got the PET CT of this patient because we wanted to know what's happening. So the PET CT revealed there was avid intake in the cutaneous thickening in the liver and the lung lesions and in the left choroid. So this was suggestive of a metastatic disease. So the left eye, if you go back to the picture, the hypopyon was basically because of the metastasis in the left eye, the chemosis, probably it was everything in the orbit and the choroid. So this was the course of the left eye. And the right eye subsequently developed retinal detachment, which we managed to settle with oil tamponade and a revitrectomy. So this was how he presented with at the initial presentation, and this is how he became at the follow-up. We lost the left eye, but we could restore the right eye. Now you can see the pupil has dilated well, and he had ambulatory vision in the right eye. So this was an infection versus non-infection in the same patient. The clinical clues were different. We had chemosis, we had a very white hypopyon, which is, if you have listened to the previous talks and the previous sessions, you have this white hypopyon. It's pointing towards a masquerade. Now these are three different patients, different phenotypes, but if you have to define, you have a choroidal granuloma on the first fundus photo, you have again choroidal granulomas in the second photo, and another lesion in the third. So just do the first non-invasive imaging, and here we have the OCTs, which give us enough clues. So we are dealing with a choroidal granuloma in the first case, maybe tubercular because of the nature of the large bump of the RPE, subretinal fluid and fibrin, intense exudative response, which is very characteristic of a tubercular choroidal granuloma. The second one is also a granuloma, but I would not call it tubercular because these granulomas are deep in the stroma. They do not produce exudation. They do not push the RPE, and they are very much located within the stroma of the choroid as seen by this arrow. So most of the times they are pointing towards the sarcoid granulomas. Of course, you would need investigations for corroborative evidence, but these are just the clinical clues I'm talking about. And the third one, many of us know, it's retinitis. OCT is to confirm the location of this lesion. You can see a lot of vitreous cells. You can see the full thickness retina being involved, also along with the underlying choroid being partly involved. Now you have the one on the left, you have these tongue-shaped peripheral lesions of retinitis. We need to look at these patients from the point of view of acute retinal necrosis. Another patient on the second picture on the right is another patient again marked by the arrow. A lot of vitritis, vitreous membranes, and you have these lesions in the periphery. So whenever you have these patients presenting to you with a lot of vitritis or a lot of inflammation in the anterior and posterior segment, many of them have panuveitis. So do not ignore the periphery because there is where you get the clue, and rather than labeling these patients of panuveitis and intense vitritis, it's actually an acute retinal necrosis. So a look at the periphery will tell you there is a large tongue-shaped retinitis lesion. Very characteristic. I think we don't need any investigations here. This phenotype is very suggestive of a progressive outer retinal necrosis. And then, we take the history, whether the patient is a post-transplant or an immunosuppressed patient or an HIV positive. So these were the cases of intense widespread retinitis. We do see cases where you just have focal retinitis, and these are more challenging than the widespread peripheral retinitis. I'll tell you why. So these are again two different patients, but absolutely similar clinical picture. The one on the left, you can see there is a lot of vitritis. The arrow points towards a focal retinitis lesion. Similarly, in the second frame is of the right eye of another patient. You have vitritis and there is a focal retinitis right at the fovea. Now, the patient presented with decreased vision, floaters because of so much of vitreous inflammation. Now, when we do the OCT through this focal retinitis lesion, and I would not do an FFA before I do the OCT because I want to know the nature of the lesion. So when we do the OCT on the first on the left side, you see the lesion is involving full thickness retina. It's a horizontal involvement of the retina. The underlying choroid is relatively spared. You have a lot of vitritis, of course, that's there in the other eye also. So this was actually after eliciting the history, doing the investigations and doing the fluorescein, turned out to be a patient of Behçet's disease. And the other one where you have this large peak, this is a typical rain cloud sign that we see in fungal endophthalmitis. So this was a fungal endogenous endophthalmitis. Now, if you remove these OCT pictures, the clinical pictures are very much similar, but you need to differentiate. One is non-infectious and the other is infectious. So sometimes your imaging only gives you the clue and you don't have to do very thorough investigations. Two different patients, similar looking hypopyon, pupil dilating very well in both the patients. The only difference is there is a bit of pigment on the interior lens surface on the second eye. Now, when we dilate, it's important to see why I lay stress on posterior synecdoche is because if you have intense posterior synecdoche in a patient with hypopyon, that means probably we are dealing with acute anterior uveitis. That is where you need to get an HLA-B27. But if you have these kind of fully dilating pupil, not showing any posterior synecdoche, but hypopyon, try to look at the fundus. If you're able to see just the glow, no details, think of endogenous endophthalmitis. If you're able to see the fundus, go ahead with the fluorescein angiography and you see this Behçet's vasculitis. So again, infectious versus non-infectious. So one, we are dealing with endogenous endophthalmitis, the other we are dealing with Behçet's uveitis, both presenting with hypopyon uveitis. So vasculitis also, we have certain clues we may have or we may not have. So frosted branch angiitis typically known to be occurring Behçet's disease, but of now lately, as Manisha also showed you, we are seeing this more in tubercular etiology also. So this was again our patient who presented later in left eye with frosted branch, and he had already undergone treatment and laser photocoagulation in the fellow eye for TB vasculitis. This similar looking young male presenting with frosted branch vasculitis, when we investigated him, took his history, he turned out to be syphilis positive. So to summarize, infectious versus non-infectious uveitis, the clinical clues are most crucial, followed by our clinical examination and then history. So identify the clinical clues, pick them up in your clinic itself, and then work up the patient. We need to act aggressively but cautiously for the infectious cause, because if we are in a hurry and diagnose a non-infectious cause, we end up giving steroids, which may be a major blunder for an infectious cause. Thank you very much.
Thank you, REEMA. I think with all those interesting case examples, you've beautifully highlighted that we can have the same kind of a phenotype and the etiology can be different. It can be infectious and at times it can be non-infectious. So are there any questions from the audience?
So now it's open for the audience interaction. We want you to ask as many questions to our by you to our esteemed speakers relative to their talks. So you're most welcome. We have a couple of minutes.
Dr. REEMA, I have a question. If you have a lymphoma, intraocular, and both brain, would you just give systemic or you would also give intravitreal?
I think this controversy has been discussed quite a number of times. If we have done the imaging of systemic, I mean the patient does not have any clue, and we know that sooner or later he's going to develop a CNS lymphoma. So the primary aim would be to give him intraocular treatment, but our oncologists at PGI prefer to treat them with systemic therapy as well.
So I have one patient, young patient with intermediate uveitis, both eyes, 6/18 vision, lymph nodes positive, came out to be Hodgkin's. Now the treatment has been done for Hodgkin's, he's in remission, but the CME is not going away. So is it paraneoplastic? Is it in fact is the
I think we need to look at the paraneoplastic because cystoid macular edema is not a feature, not really a feature of primary vitreoretinal lymphoma. And if you go back, we attended the IOSG webinar last weekend was on vitreoretinal lymphoma. So there the discussion was on CME. Why CME does not occur in it does not occur in primary vitreoretinal. It's very rare. So if it is you have treated the patient for vitreoretinal lymphoma, the CME is not going, I think take a course different than lymphoma.
So the next question is please.
We can't hear you.
Hello. I had a question related to tubercular uveitis. That if someone is diagnosed with it, then how long after ATT would you like to start steroids? When steroids are, like when it's threatening the macula and all that? What is the gap you normally keep?
You mean to say how long after starting the ATT?
ATT, correct. Do you like to keep a gap of 2 days, 1 week,
No, generally what we do in our practice is we start the steroids first and then start the ATT. It is unlike the other conventional treatments where we give the antibiotic first and then steroids start this like in toxoplasma and in other cases. Even in antivirals, we start the antibiotics first and then start the steroids. In tubercular uveitis, we start the steroids first and then start the ATT, mainly for two reasons. Because we want to avoid paradoxical worsening, which is related with ATT. Secondly, by the time we have our diagnosis and by the time we know we are dealing with a TB uveitis, we want to have the baseline liver function tests for the ATT. So we ask the patient to get the LFTs done, and maybe a week or 2 weeks later we start the anti-TB therapy, but that's primarily to reduce the incidence of paradoxical worsening.
And I didn't hear the first 1 2 talks, but I just wanted to know that do you use in any of the macula threatening non-infectious lesions, do you use IV-MP also at times or just oral steroids high dose?
No, we give IV-MP for cases like VKH, sympathetic ophthalmia, sometimes even serpiginous like choroiditis if it is involving the fovea, especially in one-eyed patients, we go ahead with IV-MP.
Thank you.
And just to add to that question of yours about ATT and steroids, I think we have to differentiate when we are treating with antivirals and with antitubercular. So that concept of starting the steroids 2 weeks after ATT is not followed now. Antivirals, of course, we all prefer that at least we've given it for 3 days and then we add steroids. But as Dr. REEMA mentioned, we basically, if you see a practical situation when you get a patient in your clinic, you will straight away start the steroids and order investigations. And by the time in 2-3 days time when the patient comes back with investigations where you are suspicious that yes, it is tubercular, you will add ATT. But there's no harm done if you start steroids
Full
either
dose.
before
So you
or
start full dose straight away because one is always scared of miliary happening
Yeah.
and all that's what they tell us.
So I think that scare should not be there. You can start it simultaneously or even before.
Thank you.
I think we need to get an X-ray chest done before for medical legal purposes. If you have miliary tubing, then you avoid the steroid. So that is a pertinent question that if it's miliary, though in serpiginous majority are paucibacillary and you'll just find a lymph node, you won't find active disease. So I was going to ask Dr. REEMA, have you done a trial? How long gap should you give? So if you have a serpiginous choroiditis, like should I give ATT after a month when it's totally dissolved, or it's partially dissolved with steroid, then give the ATT? Because your theory is that it prevents recurrence, right? So I have this one patient who came to me with serpiginous-like, but couldn't find TB in that patient that time. He had serpiginous-like activity in the other eye after a year. And we had to give steroids, ATT, we found a lymph node, and we had to give Ozidrex, we had to give methotrexate, and even after 2 years, his serpiginous is active, and his 9 months of treatment is gone. So this controversy of when to start steroids and how much gap can I give? Would I prefer gap of 1 month to get the resolution? Because if I have a paradoxical reaction at 624, patient goes back to 660. If you have got 6/6 vision back and you start ATT after 3 weeks, for a non-positive patient, it's like one is that you have found a lymph node which is on biopsy positive to be TB. Otherwise, indirect evidence. You have a Montus, you have a fibrotic calcified node, but you don't have active TB. So can we differentiate and start ATT slightly later?
I think the timing of the ATT does not really matter because it's not like that robust antibiotic which is going to act in a day or two, right? So ATT takes time. So even if you start along with steroids or a week later or 2 weeks later, it's not going to make much difference to the patient's response because the idea is to suppress the inflammation, which is we are anyway doing with the steroids. The idea of giving ATT is to prevent recurrence. You want to remove the bug from the system. So if you give 1 week, 2 weeks later,
I was speaking particularly, sometimes you just get a fresh person who comes, you don't know any of their medical history, they also don't know it, and it's threatening the macula, so you're at one hand trying to save the macula, and and you're quickly getting the investigations done, and sometimes
so
even though...
as long as you're sure it's not an infective etiology. I mean, you
So
can
that takes about 5-7 days, and sometimes even the medical specialist is not sure it's TB. It's that equivocal kind of thing. Then we have to send to Meroli, a specific TB hospital, to know whether to put on it. So in that period, would you start full dose steroids if the macula is
Why
threatened?
not? That's what I'm saying. When it's vision threatening disease, start steroids, but rule out infections. Rule out viral, rule out toxo, rule out fungal, everything that you can, and start steroids because you have to save the vision.
Thank you.
Especially the vision threatening serpiginous like basically the morphologically, if you have a placoid form of serpiginous like choroiditis, then we are going to have an aggressive course. In that case, we'll treat with optimum steroids, and they don't respond within that period of time in spite of the ATT what you are describing the severe course.
One thing,
in your clinical practice, how many times you see that the vision is lost permanently or the permanent damage is done just because the inadvertent use of the steroid? How much is this you can say you see in your practice?
I think it is very common, and the reason being that the treating doctors are not giving the steroids in adequate dose. So they feel very comfortable, they'll start 20 mg, 30 mg, they will immediately stop it after a very short course.
My question is, see, this is a different thing. My question is that when the steroid is given in a proper doses or maybe in the higher doses, and the case is was of infectious etiology. Now, how you see those kind of cases in which the steroid given by the clinician has, you can say, negative response on the vision, or you can say has that cause that loss of vision permanently.
so your question is steroids wrongly given in
Yes.
infectious uveitis.
Yes.
So we see a lot of cases like that. That was why we wanted to have this kind of instruction course. Some of these cases are toxoplasmosis. The retinitis is missed. It's looked upon as choroiditis by the treating ophthalmologist, and straight away steroids are given, and the patient comes back with a fulminant retinitis.
But none of the presentation was covering that actually.
No, Manisha's covered up. That was mistakes in infectious uveitis. When you treat thinking of it as a non-infectious uveitis.
Okay, and it is the only one example, that toxo case or any?
I have seen people giving steroids in fuchs uveitis. I have seen people giving posterior subtenon, Kennicott and fuchs uveitis, and they've come with ptosis.
But that will not cause that permanent.
Even when you are dealing with the tubercular etiology, and you keep having recurrences, so you have suppressed the inflammation by giving steroids, and the patient keeps coming back with recurrence because the basic underlying pathology has not been taken care. So we get patients who have a very badly scarred retina, and they keep coming back with recurrences and keep healing. So there again you will be having that there will be a gross loss of vision, and when the patient has come back, you may give ATT now because you don't want a recurrence to happen, but they've already got a very badly scarred macula.
Yeah, but that is because of, you can say, ATD wasn't prescribed.
So can
So
I just
another
add
one
one
is
point over here?
bilateral exudative retinal detachment, fibrinous CSR.
Yes, this is
Steroids being given wrongly.
wrongly. That the diagnosis was not of that uveitis.
Yeah. So patients have come with exudative detachment because of steroids being given.
Yeah, we have had cases of syphilis who were treated with steroids and not given appropriate antimicrobial. So the dictum for any infection is that if you treat them with only steroids without the cover of any appropriate antimicrobial, you are inviting trouble. So we have had patients who were toxoplasmosis, were given steroids, and then it becomes a totally different sort of manifestation. Then it becomes kind of atypical. You will see multiple widespread lesions. The toxoplasma lesion will cause much more severe necrosis. Patients have come back with recurrence of viral retinitis, ARN, post steroids which have been given, syphilis again. So that's why the dictum, and like I think it's been dealt with in multiple talks, the idea is to rule out infections before you end up giving large dose of steroids or even a depot or a periocular steroid.
Yeah, another point we wanted to highlight when somebody was asking about macula threatening serpiginous like choroiditis or any choroiditis. So please make sure that you do a TPHA. Rule out syphilis because many of these placoid choroiditis may be because of syphilis. So if you have a macula threatening placoid choroiditis, rule out syphilis before you start IVMP.
Yes.
You have a question.
Most
please.
of the things like Hanset-Your thing, the steroids, it could be any infective uveitis. Commonest like post-operative uveitis, whenever they think it is a TAS and end up treating with steroids and worsening of endophthalmitis. That one, then the presentation we see in addition to toxoplasmosis and syphilis, most significant, like if the patient has necrotizing viral retinitis that is missed and put on steroids, that causes the necrotic retina. So we do see such cases. So it's important, like steroid is not the only course. Not only it affects the eye, but also the systemic side effects. If the patients must be taking for low dose for months together, and they can have aseptic necrosis of femur, fractures. These are all common. So it's important that it has to be titrated in uveitic cases and to be covered under antimicrobial in a case of infective uveitis.
You have a question?
Yeah. One thing, madam, about B scan, where we don't have a view to the fundus, especially where we come across cases of endogenous endophthalmitis.
So you want to know what is your question, sir?
Yeah,
The
I want
role
to
of
know.
B scan.
Yeah, the role of B scan, I should say.
Yes, so whenever we
Because
don't see the fundus, first thing we do is
to
we
the B scan.
we
Madam,
do a
I
B.
was waiting for any words from your side regarding the B scan, because if it is endogenous endophthalmitis and we are investigating and lose time, then because since it's from behind, by the time we are
If you have a vitreous opacities in a ultrasound, you cannot differentiate between an infective and non-infective. That is the irony of the situation. Anybody have tips on the ultrasound where we can differentiate infective and non-infective?
No, I think your question is if we have no clues by clinical examination, we have just the glow in endogenous endophthalmitis, then we have the next step is do an ultrasound. The ultrasound will show you vitreous exudates. That's primarily to rule out other lesions. There is no mass lesion, there is no retinal detachment. So if the B scan shows only exudates, we take up the patient for diagnostic and therapeutic treatment.
we may have exudative detachment in case of endogenous endophthalmitis.
Yeah, so that will be shown on B scan, right?
Yes.
Yeah, that will be shown on B scan.
And secondly, there's what I have noticed is there's a South Indian training a little less towards thinking of tubercular etiology, and in North India the tubercular etiology is a little more. I have seen one patient wherein steroids were given, good retina person was dealing cases, and when the patient came to me, it was PL negative in one eye, and upon inquiry it was long duration steroids were given, and the highest induration I have seen in my life, 60/60, and but since it was too late, it was not of any benefit giving doing anything for that eye except for giving ATT for about a year or so.
So uveitis is an enigma. All your lifetime, you will have to revisit your diagnosis. We have to learn from each other's mistakes. So the aim of this instruction course is to learn. Nobody can be perfect. And if somebody says that I have mastered uveitis, no. It's a lifetime. We are having new diagnostic tools to diagnose. First, we were only having FA, then we had OCT. So things are changing. We have to learn. We have to keep learning from each other. I think you've given good suggestions
So
and
9
good
months
ideas.
or 12
Do you have any
months?
other question or comments?
We generally we give it for 9 months.
9 months. Okay.
So any questions with this? If we have no questions, thank you very much for your active participation, and it's wonderful to see a lot of people who just left, but during the instruction course they were all there at the last hours of the day. Thank you very much for being here, and I thank all my co-instructors for their wonderful talks, wonderful cases, and wonderful presentations. Thank you very much.
Thank you.